12:17, we go.
Probably get started, Chad. I mean, we're up to almost 60.
Think we go ahead and go?
Yeah, go for it.
We'll do it. Welcome, everybody. Thanks for joining. Just by the size of the group that's here already, people have missed coming to these meetings. So welcome back. We've missed all of you. So we've intentionally kind of been dragging through this because while we know COVID has been on the rise, Delta variant has been misbehaving, there hasn't been a lot of necessarily new information to share. So it wasn't for lack of wanting to engage. It was just, we didn't want to waste people's time if we didn't have any real new things to kind of disperse. But now we have some new things to disperse. So we are gathered here today to share all of that. So a couple things, just kind of frame setting to where we are. If you do not live in Yates, live or practice in Yates, Allegheny, or Wyoming County, you are currently in what the New York State Department of Health classifies as a very high area of transmission. So all of Western New York and Finger Lakes region is in the very high transmission rate. Now there is an extremely high, which is reserved for largely the southern, Midwestern, and Western states. So the upper Midwest and Northeast are pretty much in the very high transmission zone. The rest of the country is largely purple in the extremely high. If you are in Yates, Wyoming, or Allegheny, you are in the high rate, although Allegheny and Wyoming are right up against the very high threshold and likely will hit that zone very soon. So all of us are dealing with a 7-day rolling average rate of about 5% or higher at the moment. And when we really started to decelerate these calls, we were in somewhere in the 0.5, 0.7%. So we're talking a 10-fold increase in the rate of, or the incidence of COVID from the last time that we were gathering on the routine. So that gives you a good sense of what we're dealing with. When you look at least within the U of R network, when you look at the average age of the vaccinated population that gets admitted, which is a very small number, by the way, the average age is 78 years old. When you look at the average age of the unvaccinated, it's 49 years old. So not only are we seeing the pandemic changing to really becoming a surge of the unvaccinated, but it really is starting to become a surge of the younger age group than ever before. So we're dealing with that. And we're certainly, if you look at the length of stay, if you're looking at the mortality, we're doing a hell of a lot better than we were 18 months ago. But when you're talking about younger patients who were getting that sick, it's obviously a significant factor. So that's kind of where we start from today. So what has changed? So first, I'm going to talk about the vaccine mandate, because this has a lot of confusion and really evolves almost by the day. So for most of us, unless we have responsibilities in a hospital or congregate setting, and I'm going to asterisk that for a moment and come back to it, then the vaccine mandate does not currently apply to you. That is to say, any hospital-based employee or anyone who works in a nursing home setting will have to comply with vaccination, or currently by what the governor's office had said 36 hours ago, be terminated with cause as of the close of business on September 27th. So that would mean two things. Number one, not only would those patients or would those employees potentially not have access to unemployment benefits, but if you are terminated with cause and a licensed employee, then that has to be reported at the state licensure level and could adversely affect your employability and your licensure within New York State. Now, I say could, there's obviously a lot of ripples to that. Obviously, I'm not a labor attorney, so I'm not saying that we can go out and tell all employees who refuse to get vaccinated that they'll be terminated with cause and not get unemployment, because that may not be universally true, but that is the implication and what was suggested by the governor's office on the call last week. So that has people in a tizzy. Now, why did I asterisk before? And I'm staring at Nick Apostolaris right now, so he is part of this if you lease a space within one of those settings. So if you lease a space within a hospital Article 28 facility, then you also must be covered under that vaccine mandate. If you come into one of those facilities, so you are a part-time worker, or you are a vendor, or you are an EMS crew that comes in, you fall under that vaccine mandate. It is still questionable whether construction workers and the like, plumbers that come in to do a service, will be required to have proof of vaccination. It was suggested that that is potentially likely. Interestingly, the only thing that we have absolute exclusion on requirement of vaccination is a visitor that comes in to see a patient inside the hospital or congregate setting. So initially it was suggested that they would have to have proof of vaccination to enter, and they backed away from that at the state level, at least for now. Now, for private practice of home health agencies, anyone who is licensed by the state, they are using this public health emergency section 16 to implement this vaccine mandate. It was made very clear by Commissioner Zucker and the governor's office, and I'm saying Governor Andrew Cuomo age, that they are looking and anticipate expanding the vaccine mandate to all healthcare workers as quickly as they possibly can. Now, whether they will be able to do that without legislative intervention remains a question. But they, at least Dr. Zucker seemed to indicate that they thought that they may have avenues to do that without legislative intervention. We'll see. I don't know. Obviously, one of the considerations is the thought was that Dr. Zucker may be part of the Cuomo regime that would be replaced by Governor Hochul when she came in. Although it sounds like he will probably at least be around for the first 30 to 45 days of the transition, but most likely will be replaced ultimately, is the anticipation. So there's a lot of flux in that vaccine mandate at the moment, but it is becoming fairly broad. The other very big unknown that has ripples for all of us is that the Biden administration announced a federal mandate for nursing homes and used the justification that, and I'm not sure how this will be broadly enforced, that because they accepted Medicare and Medicaid payments, the federal government had domain to enforce that mandate. Now that could apply to all of us. So any of us who do not practice concierge medicine and take anything other than commercial insurance could potentially fall under that same domain. So that has raised a lot of question marks as to how extensive could the federal mandate go if they use that frame of logic. So a lot of uncertainty. I would anticipate that we are going to see more mandate, not less. And then, as Nick's pointing out, FQHC mandate coming down the line. So yes, I think we're going to see more, not less, in the coming days. And I think from a public health standpoint, most of us would agree that is a good thing. From a healthcare delivery standpoint, there are enough staff, especially in hospitals and nursing homes, who either will refuse, and for some who food services, patient transport, environmental services, while we kind of mentally focus on doctors and nurses, the reality is there are other unlicensed individuals who are paid at that minimum wage rate who are just as essential to the operational support of these institutions that have other options. I know, down here in Dansville, Dunkin' Donuts is paying over $17 an hour, which is more than our minimum wage employees get. Now, granted, benefits may be different, but for some of those folks, that may not be enough of a factor to keep them in healthcare. So we're going to see a ripple effect from this that's going to transpire over this next 30 days as we march towards the enforcement date of that September 27th. Have received at least the first dose by. Now, interestingly, and already a big question, there is the possibility of health or religious exemption, although the governor's office, again, Cuomo, was very explicit that those exemptions will be extraordinarily narrow, that the Department of Health was not putting out firm guidance as to exactly what that narrow exemption should entail, but that they reserve the right up to and including enforcement action, including withdrawal of your Article 28 status, if they thought that your exemption was overly broad. So it is going to impress upon all of us that it can't just be, oh, I went to see my doctor. My doctor wrote a note saying that I can be exempted for some health condition. It is going to have to be explicit that you meet the following health conditions, of which the only currently FDA approved health exemption is demonstrated allergy to the COVID-19 vaccination or some of its constituent parts, which is a fairly small group. For the religious exemption, the discussion is so focused that it could not only require that you state your religion, but that you are actively practicing, that you have a note from the pastor, minister, whatever of the religion that you ascribe to, that you cite the actual doctrine from your religion that precludes you from receiving vaccination, and you prove or you provide proof that you are precluded from all vaccination, not just the COVID-19 vaccine. So that gets to be very rigid and unlike any other religious exemption clause we've ever seen before. So again, that still remains to be seen, but that is pretty focused and pretty rigid in being only applicable to a very small minority. So I put all that out there because that's where we stand today. We'll see how this rolls out. For the vast majority of you on this call at the moment, it does not apply today. We will see if that continues to hold true. So that's where we stand with the vaccine mandate. I know several folks have asked, when is it coming out for private practices? Is it coming out to private practices? As of yet, it is unclear how they would exert this on private practices, but it does appear that there's a intent to extend it to all healthcare workers broadly. And whether that will also exist at the federal level remains unclear. One of the things that makes this even more interesting is that as of Monday morning, the FDA has now granted final approval and removed the emergency use authorization of the Pfizer vaccine. It is anticipated that Moderna will follow suit sometime. It could be as much as the later end of this year, but we do anticipate Moderna will likely follow suit sometime in the next couple of months. That raises interest on two camps. Number one, we know that there were folks who were holding out because these vaccines were under emergency use. Will that change their willingness now that it is no longer emergency use and is fully approved? Remains to be seen. Number two, because there is a fully approved, there is thought that it allows more legislative wiggle room to impose vaccine mandate because it is a widely approved vaccine now. The other issue that is of interest is that there is already rampant misconception. There is a conspiracy group because the emergency use is still in effect for the 12 to 17-year-old group. So the authorization is only for the 18 and up. So there is a conspiracy espousal that has already been put forward that they did not actually remove the emergency use. They only added the brand name of the vaccine and changed the end date of the emergency use authorization. That is not true. It is formally approved for 18 and over. It is still under emergency use for 12 to 17 at the moment. So I put that out there because it's already come up on several different venues that the emergency use has not been officially lifted. It was a farce and a media ploy. And obviously, I think all of us on this call know that that's not the case. So that adds a new ripple effect to it. The other two factors that are causing some email and question is the booster component. So probably worth going through that. So for immunocompromised patients, which largely is going to be patient attestation. So they are not going to have to provide any provider proofs, nor are they going to have any particular, there are guidelines of what immunocompromised could mean. However, if a patient goes effective now to any site that would provide booster doses and attests themselves that they are in an immunocompromised state, they would be given a booster dose of the vaccine. So any of us could theoretically walk into a Walgreens tomorrow and say we're immunocompromised, and as long as we sign the attestation, we'll get it. So there's that. Number two, the booster dose for all has been approved effective 8 months from the last dose of the vaccine. So for the earliest healthcare workers that were vaccinated, the earliest this will come into being is on September 20th. So we are now within a month from when many of us could start to become candidates for booster dosing. I know the U of R is going to be providing those booster doses. I've heard from several pharmacies that they will be providing those booster doses, and I know the state pods and such will be doing booster dosing as well. So there you'll have to obviously provide your Excelsior Pass and or vaccine card to show when your last dose was given. And 8 months from that last dose, you will be a candidate to receive that booster dose if you so choose. At the moment, there is no mandate or requirement for that third booster dose. Whether that will change in the future remains to be seen. So it is elective for the booster dose at the moment. I will say in regards to boosters, I'm going to ignore the immunocompromised for the moment. But if you look at the data that came out from New York State, there was about 94% antibody prophylaxis and prevention of disease within 8 months. It waned right about that 8 month mark down to about 80% efficacy at preventing any contraction of COVID. So that was really the stipulation that led to the approval of this booster dose. And that really came from New York State data. So the efficacy waned from that 94 down to 79.8% efficacious at that 8 month mark. So this is a good question. You get the same vaccine for booster as the original series. So currently what the regulation is that you should receive the same vaccine that you got for your first series, unless it is unavailable, in which case you should take whatever is available. So right now, I know there are most places are saying, if you got Moderna and you came in and say, I will only take Pfizer, but I want my booster dose, they will probably just give you Pfizer. However, the guideline is take the third dose of whatever you got the first 2 doses of. And I say 2 doses because J&J obviously didn't come till later. So it's going to be a while before boosters of J&J likely becomes a thing. I will also asterisk that and say just this morning, J&J released data that showed a significant increase in antibody spike when they provided a booster dose. So whether or not that will query special attention and get them qualified for booster dosing as well is uncertain at the moment. But we know that J&J had a slightly lower efficacy than the 2 mRNA vaccines, but it appears that the antibody response to a booster dose of J&J, which we actually knew before, even from some of the early data, that a 2-dose J&J regimen seemed to have equal or maybe even higher antibody response than the mRNA vaccines. So now they have more significant amounts of data demonstrating a more robust antibody response to a booster dose of J&J as well. But there are no booster doses approved at the moment for J&J. So that's the booster discussion. Immunocompromised, effective immediately, can get booster. They have to attest that they are in some immunocompromised state, whether it be medically or from medications they receive. Any healthcare worker can get a booster 8 months after, starting September 20th. That would be the earliest. Have you heard reports that Moderna offers more protection against Delta? Have. There was two small studies, both of a similar series, that suggested that the Moderna had a higher protection against Delta. It is uncertain at this moment. It was a relatively small number of patients that was demonstrated in. But if it is true, it's fairly negligible, is the word on the street. This even goes back to, in the early days, there was some discussion, should you get Pfizer first dose, Moderna second dose? Should you get a booster third dose of the heterologous agent? With the thought being it's a slightly different spike protein makeup of those mRNA dosing. Right now, there's not enough evidence to support that, but certainly today we have Delta. We know Lambda is starting to have some prevalence in the Pacific Northwest, although it's still a relatively small minority. By the time we get to Zeta, we may have to make new mRNA boosters by the minute, which is the beauty of mRNA technology, is they can spur out another booster in as little as probably 4 to 6 weeks. But it's just going to depend on how much variation there is from the normal spike protein configuration. Right now, the existing vaccines seem to provide pretty good efficacy. So that's the story on the booster. Like I said, if you stomp your feet and walk in and say, I got Pfizer, but I will only take Moderna, they're probably going to give it to you just to get you to move along. But the guidelines would say stick with what you got your first doses of. Visitation in hospitals. So because of the high rate of spread in the community, we are seeing some contracture of visiting policies once again. It is not that they're banning visitation altogether. I'm going to read it because it's hard for me to remember every piece of this. So this is going into effect for strong as of today. I think all of the U of R affiliates are following suit, and I think Rochester Regional has a very similar, if not exactly the same policy as well. So this will become the new norm, if you will, for almost all of the regional hospitals. So each patient is allowed 2 visitors. One can visit per day for up to 4 hours. And there's no changes or exception to that approval process, except and unless it's end of life or that kind of situation. OB will continue to allow 1 support person and 1 visitor or doula during labor, and the support person and 1 visitor for up to 4 hours after delivery. For COVID positive patients, only 1 support person, no visitor or doula is allowed. Visitation will no longer be allowed for COVID positive patients unless they meet the end of life criteria or some of those other restricted circumstances. All other visitor exceptions are in place for behavioral health, emergency department, surgical areas, outpatient areas. That will remain as is today. Pediatric patients will be allowed 1 designated asymptomatic support person who can remain with the patient 24 hours a day. And non-COVID infected patients may have 2 designated support persons with overnight visitation at the unit's discretion and ability to house them. So that's for pediatric patients only. So like I said, that goes into effect today and really will be pretty much regional with maybe very minor tweaks from what I just read out. I'm going to shut up about the school part. I'll let LJ cover that, but it was notable that Governor Hochul yesterday basically said that all schools will have masking mandates, and to enter the school, you must be masked. So that supersedes this school system by school system decision-making discussion that we were discussing before. And she obviously will have much more insight and intellect into the pediatric and school stuff than I do. So that's where we stand right now with incidents, vaccination, hospital policies, immunocompromised, and masking. I do think what we have heard both from Governor Hochul and from folks who have talked to her inner circle is that we are likely to see a much more collaborative process and maybe less top down than what was felt to be in the Cuomo administration. People felt like it was a very top heavy decision that then kind of radiated downwards. At least her speech and her higher inner circle has indicated they plan to pretty much follow the instruction and boots on the ground experiential recommendations from Department of Health and the counties and at the legislative level. So take that for what you will. If you like the central decision-making authority, you may be less impressed with the Hochul administration. If you like the collaborative, there will be more voices at the table. You may be happy with what you're getting ready to see, but it remains to be seen. And I don't think we're going to see a widespread unwinding of what was left, at least by policy effect, from the Cuomo administration at this point. So with that, I'm going to shut up and I'll turn it over to LJ to provide her 2 cents.
Thanks, Chad. I'm going to be relatively brief. The most important thing I can tell you all, and you should have received an invitation for this, but we'll include a link in today's messaging. There is a Finger Lakes Schools Reopening Task Force Health and Education Forum tomorrow night, Thursday, from 7 to 8:30. And so that will be an opportunity to one of those collaborative conversations that extends across the Finger Lakes counties to review what the guidance is, what the processes will be expected both from schools and then from our primary care teams. To just give you a little preview on that, and I will say, I don't feel like I'm as well equipped to answer a lot of questions because I have been out for an extended absence and I'm kind of coming back up to speed, but I'm enough up to speed now from the right people to say that we're pretty much expecting almost the same guidance protocols, screening, testing, et cetera, as before, not any substantial change. The couple of things that will be different are that, and many of you probably have seen this from your own school districts, that we are not anticipating there's any requirement for daily written or electronic attestation for student symptoms. There's an expectation, I think, that parents will keep their children home if they're sick and seek medical attention. But that one piece about that electronic screening does not appear to be part of the standard recommendation of what's coming. In terms of, however, assessment of kids, all kids with that long list of symptoms that we've been following for the last 18 months should be assessed and evaluated and tested for COVID. The same types of alternate diagnosis protocols, et cetera, stay in place. We do anticipate, and we'll know more tomorrow night when Brenda Tassini, I think, will be presenting this, that for testing, a nasal turbinate swab may be acceptable now at this point if getting a true NP swab is not feasible for a child. Although the NP, the deeper swab, is still the lab preference. But I know many of you had reached out asking, just feeling like that has become, yet another barrier to having people actually bring their kids in to be tested. The one thing I wanted to emphasize is that PCR testing is still the gold standard, and that is what is needed for a negative test. So for those of you who've been asking questions about that, that'll be reiterated tomorrow night. I think the other thing I wanted to mention is that there was a forum on social emotional well-being for kids that was hosted by the Schools Reopening Task Force that happened back on August 12th. And we will also, in the mailing for today, and emailing for today, put in the link and the recording and the slides from that for those of you who were not able to attend that. The other thing I just wanted to bring up is that many of you, I'm sure, are completely immersed in calls from parents around exemptions from school. And I wanted to be sure that everyone was aware that, really, I think that all of us land very solidly in the camp of what the AAP has said. It is really important to get kids back to in-person school. Remote learning has not been a positive as an extended form of education or social emotional support for kids. And so really, there should be hardly any medical exemptions that would keep a child out from school. And so there is a letter that's being finalized. The team over at Rochester Regional and Larry Dank and RGPA in particular sort of champion this. A letter explaining why that was important and why, as a collaborative community of pediatricians and family physicians and childcare providers, we think it's really important for kids to be back in school. And that medical exemptions really have to come from the specialist, a subspecialist that's working with a child and family, if there is something that's exceptional in that space. Obviously, everyone is able to do whatever they feel is right for their patients or for their practice. But if you would like a copy of that letter to be able to utilize as speaking points or as something you would want to send out from your practice to your patients, just shoot me an email and I'll make sure that you get that. Lastly, I just wanted to, excuse me one second. Lastly, I wanted to just mention that our vaccine efforts are really, really important right now. And the vaccine efforts in primary care are what are making the difference. So I know I've talked about this before, but if you are able to expand your vaccination efforts beyond what you're currently doing to offer it to caregivers as well as to patients, for those of you who are in pediatric practice, it's really something that would be important. And if you have not stood up vaccination in your practice yet, we would like to help you do that, because once that vaccine is approved for the younger kids, we need to be ready to roll. So please let us know if we can help in either of those efforts for your practice teams. And then the last thing I just wanted to mention is that I spoke with some of the GCH pediatric practice team today about what we are seeing currently in terms of COVID vaccine, of COVID rates and hospitalizations for kids. And we are seeing 1 to 3 patients in the hospital at any given week. Some of those are incidental diagnoses of COVID, kids who are coming in for other things and then test positive. But the thing that we need to be ready for, because the rates are rising, we're going to start seeing more of the MIS-C cases again. And so I just think our teams have been prepared for that in the past. We need to be ready for that. And if you are seeing patients, counseling families about what to watch for after COVID, what to be concerned about, and having your practice teams who are doing triage calls, et cetera, be ready and aware of that, I think is really important. And that's it. Join us tomorrow night if you can. I think that'll be helpful.
Beautiful. So a couple things one that I screwed up, and so I'll clarify. And one that I think is a good question that I will address. And then one that's just a good point going forward. So 3 things. So I said 18 and over was the FDA approval for Pfizer. It's 16 and over. So I said that wrong. So I apologize. Another question that actually 2 folks asked, which is a good one. If we do not proceed with the booster, does that mean that our vaccine status will expire? So this has not been clarified as of yet. Currently, the Excelsior Pass covers 12 months from date of vaccination. The state has not said, nor has the hospital weighed in as to what will happen after that. But I have every anticipation that the booster will be required at that 12-month mark. Again, I'm saying that purely on my own reading of the tea leaves, not that I have any insight whatsoever. But I will be somewhat surprised if there's not an expectation of a booster by the 12 months mark, at least to maintain the coverage of the Excelsior Pass and the like. So certainly we'll let you know more about that. There's been no formal output about that I've seen, but that's what I would say is most likely to occur. Final piece is the cadence of these meetings. So, we had decelerated because it seemed like there wasn't a lot of information. Now the information has fired up, and obviously we're in a different place and we're kind of seeing a different surge status. So, we were talking, I think right now we'll say weekly. And if it looks like we have nothing to offer, we'll cancel. We'll try not to waste your time. But just while it's coming fast and furious, we'll hold the date and try to make sure we're providing this feedback as quickly and as usefully as possible to everybody. But if we do think we need to cancel, we'll try to do that with advance notice, so that we're not just holding a spot on your schedule. And then, of course, there's no legal obligation that you come here. So if you choose not to come, we will not hold it against you. But we'll be here waiting for your appearance if you so choose. I think that covers everything. Renee, anything else that you had or that I didn't cover?
Nope, I think you got it all. Thanks, Chad.
Woo-hoo. All right, I think I've addressed all the questions I've seen in the chat. So if folks, we got a couple more minutes. So if folks either have questions or things that they want to address or any other corrections that I screwed up, speak now. Not seeing anybody popping off of mute, nor am I seeing the chat room light up. All right, we'll call it with 8 minutes remaining. So for now, we will reconvene next week, same time, 12:15 on Wednesday. People have questions, like always, don't hesitate, feel free to send them our way. And we will plan on seeing you next week, if not before.
All right.
Thanks, everybody.
Hi, everyone.
Take care.